Social Health Authority and the Social Health Insurance Fund. Because in just how many days now? 4 days to go for the rollout of that, beginning the 1st of October 2024. And my word, what a journey it has been for this transition from NHIF to SHA, what with court cases and public participation, the rush to make sure that they regularize those matters that were raised by the court. And now here we are. But still, even with this entire journey, not smooth. We will get to some of those. I actually want to see if we can listen to the Cabinet Secretary, Baraza. That's bite number 6. Where she talks about what's happening and how much people really know and understand about this, even with 4 days to go. Yes, let's listen.
The message has not reached quite well. The coverage is not good. At the higher level, there's a lot of things going on in social media that may change the vision of Kenyans. They will not understand that this is for their benefit. We need you to inform them that SHA is for their benefit. They need to register so that they can access care.
So let me give context to that. She was speaking at a meeting with her counterpart, Professor Kithure Kindiki, where they were launching, the sort of rollout with members of the national government, administration officers, chiefs, and that sort of those officers to go out and spread the word about SHIF. But even by the government's own admission, this is not well understood, and therefore the uptake will, not be as positive as they might have intended. But why is that, Sam? There is a lot that we still don't understand about SHIF. There's many questions about how we got here, about procurement processes, about the cover, about how much salaried Kenyans particularly are going to be charged, what the services that you will get under that. And in fact, the most basic question of why did we even need to transition from NHIF to SHIF in the first place, Sam? The questions just aren't quite answered with 4 days to go to the rollout of what is a massive transition in the country at the time.
I must admit that there's quite massive ignorance across the country about what exactly is happening. And I've seen someone asking, I don't know whether they were joking or they were serious, saying, what is this SHA, SHIF, and what is the difference? Yeah. So let me spend just a little time to just explain what I have read. So first, let's talk about the Social Health Authority. So this is an institution, as the name suggests. It is an institution whose work is to manage the new medical insurance scheme. So under the Social Health Authority, which already has a board of directors and at the same time has an acting CEO with 0 employees, bearing in mind that currently it is the NHIF employees that have been acting in some of those positions. So that is the institution that is supposed to be rolling out everything else that I'm going to say starting the 1st of October. Never mind, they have no employees. So under the Social Health Authority, there are 3 funds. The first one is Primary Healthcare Fund, which is a fund that is supposed to be financed by the government to the tune of 50 billion shillings that is supposed to provide the universal health coverage at every institution that offers primary health care. That is level 1, 2, and 3. I'm talking about dispensaries, health centers, and some level 3 hospitals that would also have some maternity services where you can actually deliver. So that is the Primary Healthcare Fund, 50 billion worth of investment. Do you know how much the government has put in? 4 billion shillings. That is less than 10% of what is required.
Based on budgetary allocation.
Yes, it is being rolled out on the 1st of October. Yeah. That's the first fund. The second fund is the Social Health Insurance Fund, or SHIF. So SHIF will be based on contributions by members. You have to register, Yvonne. You have to apply to the authority to be registered as a member. Once you're registered, then you have to make a contribution. If you're salaried, meaning you have a monthly income, it is 2.75% of your salary. No cap. As it is. If you're not salaried, meaning you're in the informal sector or you have no known work, then the government is supposed to determine how much do you make in a year. There could be self-declaration, but also there's a means testing instrument that the government is supposed to be rolling out to determine if you have someone who rides a boda, they're not in the formal sector, how much income does his or her household make in a year? If they determine that you make 100,000 shillings in a year, they're going to calculate and say 2.75% is 2,750 shillings. You pay it in an installment once. So not every other month, it's once. So that is the Social Health Insurance Fund. It mirrors what has been happening with the NHIF. If you're not registered under SHIF, you cannot benefit from the primary health care because you're not known. But they are saying that once you go to the hospital, the first thing will be to register you, and immediately you can benefit from the primary health care, which is as far as level 1 up to 3 is concerned. The third fund is the Emergency, Chronic and Critical Illnesses Fund. It is supposed to be funded by the government through Parliament, which allocates resources. The estimate as of now was it supposed to be funded up to 75 billion shillings. How much has government put in? It has put in 2 billion shillings. It is being rolled out on the 1st of October 2024, but there are several services that will not be accessible because of the lack of the budget. So that's the difference between those three funds. At the end of the day, Social Health Authority is the body that is going to manage all these things and also manage the membership. Now, you ask a question about, I forget what you asked.
Well, I think it was just basically that, but we don't know much about this. That by far has got to be the most succinct explanation that we have had in this country about what that's where I was heading to, about SHA, SHIF, what all these things are, and it's not coming from government. It's not coming from the people who own this process, who are rolling it out, who are set to implement it. That took less than 5 minutes. It's taken them months to help Kenyans understand what it is. Instead, what's the sort of messaging we're getting from them? This is what's happening. You have to register. In fact, there was a time, remember when we were being threatened with denial of other government services if you do not register, with SHA and therefore start the contributions. I mean, it's always about the money, isn't it? Okay. But anyway, the question was, now we understand what it is, but then there's questions. For instance, there is a digital health system around it. There is, of course, those contributions of 2.75% and what you get, the services that you get, because our understanding, at least, and we had the former CS here on Newsgang, Susan Nahumicha, a couple of months ago, to just take us through, first of all, why we're moving. So the idea would be that if we are changing, it is for the better. But from what we are seeing with what services we're supposed to get, Jamila, is it any better than NHIF in terms of the services one would receive? So you have registered with SHA, you have done your mandatory contributions. What are you getting? Are you getting better services compared to NHIF?
Ivona, I have so much to say.
The floor is yours.
You know, one of the questions that people have been asking is, what was so wrong with NHIF that you have to do a whole overhaul, spend so much money, start everything from scratch, so that you can fix what the issues in NHIF were? Because even if you remember, NHIF was in place for a long, long time.
And it had its issues, though.
It had its issues, and I'm not saying that it didn't, but it took a really, really long time for people to start seeing some of the benefits that some people did see with NHIF. I was speaking to a doctor and he said, up to about 10 years ago, I'll give an example of dialysis, okay? Until about 10 years ago, for doctors to do 3 sessions of dialysis, to put a catheter and to do the dialysis, you had to pay 30,000 shillings, okay? And at the time, the only hospital that had a dialysis machine was Kenyatta National Hospital. And people would come and queue and queue. And in fact, the doctor was telling me sometimes they'd watch patients die because they did not have the 30,000 shillings. And then suddenly now, NHIF started paying 9,500 shillings per dialysis. And other hospitals realized, well, we can actually make some money out of this. So medical, I don't know if you remember the MES program, the medical equipment program under President Uhuru Kenyatta. Dialysis centers were put under that program. Yeah. So now there was demand for the service. And because NHIF was actually willing to pay even private hospitals the 9,500 shillings for dialysis. And then now private hospitals started coming up. Now dialysis machines were available, dialysis services were available, and it became pretty widespread because people were paying 500 shillings for the service. So they stopped seeing that people walikuwa wanahangaika wanateseka because this service was available. And that was just one example that I was giving. NHIF did have its issues. But why dismantle it all and start all over again? I'll give an example of what is being recommended now under SHA, or what is being proposed under this new fund. I'll talk about diabetes treatment, because Yvonne, this is a hereditary disease. My family suffers from diabetes. I have several family members who have diabetes. And we're being told under this program it's 4,300 per year for diabetes treatment, diagnosis, and that. Yvonne?
Per family, right?
Per family. That's per person.
Per person in a family. 4,300 per person in a family. Let's say a father has a disease, a mother has it, maybe one of the kids has it.
Okay.
And then now there's this medication that for the injection that diabetes patients use. It's called Mixtard, and it's the one I think that is available in government hospitals and government facilities. It goes for about 500 shillings. So maybe you use one a month, okay? But then in a year you'll need about 6,000 shillings. Hiyo ni Mixtard, dawa ile unajidunga. You've not done any tests. We've not monitored you. Because diabetes is a disease that can kill. Because one, you can get kidney failure. In fact, statistics tell us that diabetes you're likely to, you're 2 times more likely, you're 10 to 20 times more likely to get a kidney failure. As diabetes, yes, diabetes is a leading cause of kidney failure.
Right.
You're also told that you need to go for regular checkups. You need to do scans. You need to do ECG for your heart. You need to have your eyes checked out, because diabetes is a leading cause of blindness for people under the age of 65.
Yeah.
And then you're 2 to 4 times more likely to get a heart attack and a stroke because you have diabetes. So, and you're 20 times more likely to get amputated.
Yeah.
Not because of an accident or anything else, but because you have diabetes. And because the high cost of all this, to avoid this, you need to have regular checkups. You need to be going for to be checked. Let's check your kidneys. Let's check your eyes. Let's check your heart. Let's check all these things. And you're saying 4,300 shillings a year for all that? I wonder, Yvonne, if there was any consultation that was done with doctors.
Yeah.
Because if there were consultations were done, they did not listen to this consultation, because no doctor in his right mind would recommend 4,000, because there's something wrong here, Yvonne. And there's a question we've been asking ourselves. So you're going to make people pay 2.75% of reduction in their pay. For someone who earns 100,000 shillings, that means utamkata 2,750 shillings per month and a total of 33,000 shillings a year. And you're giving them 4,300 shillings for diabetes care. Where is the rest of the money going?
Right.
So there are all these questions. I'm just giving one instance here, diabetes, but there's also hypertension, which they put 3,000 shillings.
Per year.
Per year. Dawa peke yake.
Once per year.
Dawa peke yake. Ujaongea consultation ya daktari hapo. You're saying for glasses, 950 shillings? Okay, 900 ni frames. 50 shillings ni ya nini? Ya kulipa daktari. So let's say you need eye drops. Maybe you need antibiotics. Maybe you need to go back for review.
Even the lenses.
Even the lenses,
which is
kuna frames na kuna lens.
Which is the dawa.
The dawa, yeah. So pengine unapata eye infection, because even us who wear glasses.
And what about the dental?
What about the dental?
The dental is the one that's
1,000 shillings?
No, it's 2,000 shillings per family per
year. Wow.
So
per family
one
per
tooth
year.
per person. Okay.
I'm ceding my time. My point has been made.
I think you can't even...
2,000 shillings per
family. Per family.
Sorry, per family per year.
Yeah.
Dental.
Even in a government facility, by the way.
But...
I mean, let's imagine a typical, family of 2 parents and 2 children. Let's just, for example's sake. So that's 4 people in a household to split 2,000 shillings for dental care for an entire year. If you have children, you know that visits to the dentist are fairly frequent. That's not to say, adults don't need it, but these are the sort of amounts that we're looking at. even at a government facility, a root canal, an extraction, gum infection, those sorts of things.
But also, actually, your expectations are too high. That money is not available.
Oh, okay.
So there's no budget as we speak.
Okay.
Remember I told you the primary health care has not been funded?
Okay, so why didn't we...
later.
Let me ask. So why didn't we just stay with NHIF until such time as the financial situation of this country improves? I mean, some things seem like basic common sense, no? I mean, it's perhaps you have well-intentioned and there is all of these things we want to do in terms of primary health care, emergency and chronic care, well and good. But if you don't have the money to fund it, must you roll it out in this financial year?
There's a date that was set of 1st of October.
And that date is cast in stone?
There's the deadline of November 22nd.
Okay, so what happens if we get to November 22nd and we don't have that? What? We fall off the face of the earth? The world ends?
We'll speak to Linus.
I mean, I'm just, you know, it seems the government has this invisible gun to its head for God knows what reason. I mean, if you don't have those funds, even in laws, you, put a clock on things. We've kicked the can down the road with several matters before. Why would you have an emergency and chronic care fund and you have only 2 billion as opposed to 75 billion that you had intended for it? So just don't roll it out. Just put all of this on hold. I mean, am I...
Yeah, those questions very shortly, Yvonne, will be overtaken by events.
Okay.
And that's not long from now. That is on the 1st of October, which is next week, Tuesday. What will happen is, legally, NHIF ceases to exist. Remember, the last admissions will be on the 30th. And now the new arrangement will be taking place, including the Social Health Insurance Fund, SHIF. And very shortly, the country will be where exactly it is with the CBC education system, which is, it's too late to look back. It's, what you can do is, how do you improve? How do you fix? How do you make it work? And I think from October 1st, that is a conversation that this country must have. Of course, there are questions about the rush. There are questions about the modalities and whether the model is going to work any better than NHIF. But all that will have to be subjected to the scrutiny. And the new team, and some maybe should have mentioned, there's already a change of leadership at the top of SHA. You know, we now have a new chairman.
Right.
That was really quick. And,
7 months, I think, or 8, or was it even a year before the previous?
It didn't last a year.
Yeah, it didn't last a year.
Yeah, and the question, of course, is why?
Why?
Why? What is that about? And the good thing with this country is everything comes out.
Yeah.
Eventually.
That's true. Yeah. So let's talk about some of those questions, which, you know, and thanks, Linus, it's probably a moot point. It just, you know, seems a little frustrating that, you know, a government can move in this fashion. But Nisawa, the first is coming, as sure as the sun will rise tomorrow. The first will get here and we will be with SHIF. But Sam, there's also questions about, so now we are procuring a whole digital health system that will supposedly now manage all of this. I remember when former CS Nahumicha was here giving the justification of the move from NHIF to SHIF, and that there was massive corruption in NHIF, and that one of the ways that they were trying to eliminate that now with SHIF is that the systems are largely digitized, right? But even that digitization has some questions about how it was procured, who is providing these services, at what cost. I want us to listen to PS Harry Kimtai, who's the PS for Medical Services, where he talks about why they opted to go for direct procurement. And then he goes on to explain the companies that have been contracted through this direct procurement process at the cost of about 104.5 billion shillings. Let's listen.
Ni kampuni ambaye imesajiliwa kule Warabuni, Dubai, ama Abu Dhabi. Kusema kwamba imekuwa registered hapa Kenya ni kwamba baada hiyo, kama kampuni inataka kuendelea kufanya biashara hapa Kenya kulingana na sheria zetu za kusajili makampuni, ni lazima pia wajiandikishe hapa Kenya. Convergence ni kampuni hapa Kenya na ni sisi wa Kenya hapa ambaye pia Safaricom waliona kwamba kwa sababu ile kazi wanafanya waje pamoja wafanye kazi hiyo, kwa sababu hawangeweza kufanya, Safaricom hawangeweza kufanya zile model zote, wangehitaji makampuni zingine wafanye pamoja.
So Sam, questions about this procurement, what these companies are supposed to do?
Right. So it is important to note that there's a name for what Safaricom is supposed to be doing. I just like to confirm so that I don't say it wrong. Well, I'll find it, but they're supposed to come up with a program that allows hospitals, that is the service providers, Social Health Authority itself, KEMSA, Nursing Council, Dentist Council, an integrated system that allows everyone else to meet, to share information, to access details about patients, and of course to also trace how the supplies are flowing. That is a pharmaceutical and non-pharmaceutical. Brilliant idea. But at a cost of 104 billion shillings to be done by Safaricom, a telecommunications company, there are questions that are being asked. Because if you look at the consortium itself between Safaricom, Apero, and Convergence, at least Safaricom is known and what they do. If you look at Apero and the shareholding that we looked at in our earlier story here, it takes you into several layers of ownership to an extent that you can't even tell who owns what. A director here has shares, but the bigger owner of that company is a holding company. This director does not have shares there, but they are just directors. I mean, it's quite convoluted to even get to understand what's going on. Again, these are companies that have been registered in July 2024. Never mind, there's an explanation that Apero had to be registered in Kenya because that's what the law says if you're a foreign company. I wonder, Smartmatic that provided election services, whether it was registered in Kenya for it to serve IBC in the last election. If you look at the law, it talks about circumstances during which you can actually go to the direct procurement. And yes, there's one of the provisions that I think the PS tried to refer to there when he said about if this is a service that had been provided by a supplier and only that supplier can now provide that service. But the example that is given, it is the kits that are given to the community health promoters.
Yes.
Were there 100,000 of them?
Yes, yes.
You want to tell me that you're going to spend 104 billion shillings on this supplier because they provided 100,000 CHP kits? CHP kits that are taken to the villages by community health promoters to go to families and check on how they are doing and also gather data. So because of that provision, that's why you're going for a tender that is worth 104 billion shillings? The other question that must be asked here. So, on estimate, on a good year, when everything is working perfectly, the Social Health Authority would have control of 273 billion shillings. If that rises, it could be 300 billion shillings.
So a third of that?
A third of that is going to buy a system. Are you telling me the problem with the National Health Insurance Fund, NHIF, was a system, and to correct it, you need a system that cost 104 billion shillings to be paid up front by some investors, recoverable for the next 10 years?
That's what they're telling you.
Remember, to recover in 10 years, you need to take some 10 billion shillings every month. Where is that money going to come from?
Yet we don't even have money for these other funds.
Exactly. And the analysis that we were doing earlier and looking at the moment, let's just do the math. So assuming SHA is working very well, it has 300 billion shillings of revenue in a year. And it does not come in a month. It comes progressively. So 300 billion shillings, they're allowed to spend 5% of that on administrative costs. That gets you to 15 billion shillings. At the moment, NHIF's payroll is worth 6 billion shillings. Let's assume the Social Health Authority implements a payroll that is of similar size, 6 billion shillings. The operational costs that are required, you can put an estimate. But on the face of it, 15 minus 6 is 9 billion shillings. This 9 billion shillings is supposed to finance the consortium monthly installments, and at the same time finance operations of the organization.
Yeah.
So essentially, who is going to pay for this? Because you're implementing it, it has to be paid from the same. There are questions, and that may begin to explain to you why leadership at the Social Health Authority had to change. Because there were a lot of things that were being done to ensure that this rollout meets the deadline of 1st of October 2024. But you can clearly see the government itself is not ready with resources. The government is not ready with a system. But ask yourself, the National Hospital Insurance Fund has been operating in this country.
Yeah.
They've been settling claims.
Yes.
Never mind, sometimes resources are not available.
Yeah.
Never mind, some county governments that are looking forward to benefit from the Social Health Authority have not been remitting NHF deductions. But they have been settling
there was
claims.
something, yes.
There's a system they've been using.
Yes.
What would it cost to take the same system, build up on it progressively, so that at this time as you speak, so you roll out on 1st of October,
With
you admit
what?
a patient in a hospital, how are you going to claim?
Data, yeah.
You have no system. The system is to be built by the consortium. How are you going to claim? Are you going to use the NHIF system? If you're going to use it, and the vision is to ensure that you have visibility, traceability of all the products and non-pharmaceutical and pharmaceutical, how will you do it?
And a good question, that is another question I want to ask, these uncertainties, is have medical institutions been onboarded into the system? Has anyone been onboarded?
But the system doesn't exist.
Exactly. So doctors are supposed to, institutions are supposed to
Maybe
apply, apparently. There's a WhatsApp group.
It seems to...
Apparently they're supposed to...
be the way
they're supposed to...
the executive runs things.
To apply, to be onboarded. And then if you accept, they'll tell you you'll be onboarded, but you're given only 2 days to respond. So kubali na tumekwambia tutaka ku onboard. And then now hospitals are wondering how will they engage with the system if we end up having that system? Because 2nd of October, there needs to be something in place.
Yeah.
So how will the system be run? Will people be given cards? Will they use the NHF cards? Will they use biometrics? And then what happens if there's an emergency case? Mtu amekuja. So do you need to, will you be stabilized?
According to what Sam said is when you get to hospital, they register you first before they give you services. But that's in an accident.
That's in an accident situation.
Right.
So were there any trials done? Because I keep thinking that this thing has been pushed. Has there been any trials done?
Yeah.
In fact, even how the payments will be made? Because you'll correct me if I'm wrong, Gituku, but so you are treated and then invoices are sent and then you'll be paid after 3 months. So what happens to those small hospitals and health centers in the villages? Will they be able to sustain for 3 months as they wait for the payments? And then finally, Yvonne, as I finish, the government announced that they're planning to register 12 million households. Yesterday, when we had that meeting, which had the Minister for Interior and the Minister for Health, PSAs, wakisema tumeshirikiana, sasa we're going to use the same system that was used to register 6 million farmers for fertilizers.
Subsidy, yeah.
So 12 million households, around 38 million people in the next few days. How will that happen? Because come 2nd of October, there has to be something. Linus amesema sheria imesema kwamba NHIF ceases to exist.
But Jamila, you know, all that data, you know, once you collect it, it's not just that you register the people and you're like, okay, we've got Jamila, we've got Sam, we've got Linus. You have to clean up that data. You have to take it through, you know, a validation process and ensure that what we indeed got from Jamila here is indeed the facts, that these are the number of people in a household, this is the whatever. Then they're using the means testing for the others. We all know means testing and how it has worked. You talk about some of the smaller health institutions. You remember rural hospitals have been complaining about lack of reimbursement from NHIF. So the other question I have is all of those issues with NHIF, have those been sorted out? Because you have to feel for those who run the rural hospitals, who to date are still waiting for reimbursement from NHIF, which will cease to exist. And Sam is smiling.
30 billion.
30 billion shillings, huh? So what happens to them and their claim? Who do they start to chase if we're saying, okay, as of 1st of October, NHIF as a body will not exist? And remember, that's been an imperfect system. Now we're moving into this new one. I mean, you see, this is my point. And even as we say the clock is ticking, the law is... Laws can be stayed. Laws are made, is it the law being made for man or man being made for the law? We made these laws, right? We can stay the laws. We can, you know, go back to Parliament. What is Parliament there for? So this may be a well-intentioned program and initiative, that is fine, but can it be done progressively? Because at some point they also said if you are registered with NHIF, you would not need to register again. But granted, and they have a point, that circumstances can change and we want to be sure that we have the accurate information, fair enough. But to do all of these in these couple of days, a system, registering people, validating that data, testing the system. I remember Emmanuel Manyasa saying that the means testing system for the university funding model had itself not undergone testing. So has the means testing system...
Not AI. Sorry.
No, the information I have is that actually that means testing instrument has
Samila, you are out of order.
has massive challenges.
But yes,
we understand that in a test that was conducted in one of the rural counties in up north, a family that is extremely poor, the means testing instrument was used on them, and it showed they should contribute 20,000 shillings.
Oh wow!
These are people who own almost nothing, no technology within reach. But also, Yvonne, remember, there's a high chance that these laws could actually be unconstitutional.
Yeah.
Remember, there's a court, there's a case in court.
Yeah.
That the Court of Appeal judges last week stayed the implementation of that decision, that finding of unconstitutionality.
Yeah. Well,
I mean,
the case.
we're staring at some challenges quite ahead. And again, like she says about the rural hospitals, these are the institutions where people go for primary health care.
Yeah.
So government is supposed to reimburse or send resources to them. But when you assign only 4 billion shillings for this level of hospitals out of 50 billion shillings, honestly, what do you want people to do?
And when it's the same government or NHIF that owes rural hospitals 30 billion, wow, that math is not mathing. Okay, Jamila.
Final words.
Should we use AI to end the show?
Wacha tu since Gituko alikuwa na masibu wiki jana yote. Sam, you can start.
Okay.
Yeah.